Good morning and welcome to the North Yorkshire and West Yorkshire Joint Health Overview and Scrutiny Committee on Vascular Services, and I am Councillor Liz Smage, Chair of the panel. Does the panel want to introduce themselves, please, Councillor?
Councillor Graham Latty from Leeds.
Good morning, Councillor Betty Rhodes Wakefield. Good morning, Councillor Helen Hayden Leeds.
Good morning, Councillor Stephen Baines from Calderdale.
Morning, Councillor Colin Hutchinson from Calderdale.
We are having a few technical difficulties this morning, so we are working on the wrong names coming up on screen at this moment in time. Okay. We've got apologies from Councillors Clark and Soloway from North Yorkshire, and we're hoping that councillors from Bradford will be joining us shortly. Thank you. Do the ladies and gentlemen from the NHS want to introduce themselves? And apologies if wrong names come up for yourselves.
Thank you, Chair. I'm Matthew Groom, Regional Director of Specialised Commissioning for NHS England.
I'm David Black. I'm Medical Director for Commissioning for NHS England.
I'm Neeraj Bhasin, Vascular Surgeon Associate Medical Director, Calderdale Huddersfield Foundation Trust, and Regional Clinical Director for West Yorkshire Vascular Services.
My name is Matt Graham. I'm the Director of the West Yorkshire Association of Acute Trusts.
Sarah Halstead, Senior Service Specialist for Specialised Commissioning in NHS England.
I'm Jill Galt, Head of Communications and Engagement for Specialised Services in the North of England with NHS England.
Vicky Pickles, Director of Corporate Affairs at Airedale NHS Foundation Trust.
Right, okay, thank you. Oh, I think we've got the technical difficulty sorted out. Right, okay. Minutes of previous meeting then. Do we agree the minutes of the previous meeting as a true record?
There's just one, page 6, paragraph 3, where it says, stated in documents provided that 20% of patients would meet their 45-minute target. Well, 20% meeting the target doesn't seem very good. I think there should be a not meet their 45% target, sir.
Other than that, do we agree them as a true record? Yeah, with that correction. Thank you. Are there any matters arising from the minutes that anybody wishes to raise at this point in time, or will be covered later on in the agenda? Anybody got any interests they wish to declare?
I am a publicly elected governor of the Calderdale and Huddersfield NHS Trust.
Thank you. All the debates will be in public today. We don't have any notifications of any deputations or petitions. So we move on to item 5, which is the consultation feedback report. Do you wish to introduce this at all? Bearing in mind, please, that we will have read the report in detail and we'll have plenty of questions. Thank you.
Thank you, Chair. I'll just do a quick introduction and pull out some key points if that's okay. So this report is to bring back the recommendations from the independent consultation that's been completed that closed on the 17th of January. So we had 385 people or organisations that participated, including vascular patients, carers, staff, etc. And you have the full report in there, as well as the key findings and some of the considerations of the alternative options that were put forward by members of the public as part of the consultation. So members may remember that we came to earlier joint OSC meetings to present an early version of the engagement and communications plan, and there's some helpful suggestions which we incorporated into the plans going forward. And so through the consultation period, we've had additional events in Huddersfield and Calderdale as requested. We've also had quite a significant online presence through the Trust, the CCGs, and across the local system. Several media releases with some high-profile interviews on BBC Regional News, and we've mailed out to over 1,000 vascular patients, specifically advising them of the events and asking them specifically for their feedback, as well as some dedicated focus groups with renal patients as well. So you'll see from the feedback report that there is quite a balanced position, but there is a regional variation in the feedback received, as you would expect to receive. So if you were saying your closest hospital was Bradford, then you would support it by 79%, but of course for Huddersfield, only 14% supported that. Of note, though, was that 57% of vascular patients supported the proposal, and also the older age group, they showed a greater support for it, of 51% for those over 75, as opposed to younger members. There were quite some interesting themes that came out as well, which we would want to consider as we move forward. There was quite a lot of support for the moving towards centralised care and making sure that the locations are accessible for people and services do retain where they can in the Huddersfield and Colesdale area. And also some feedback around the not going to one centre. 2 centres was much more preferred than one. But there were some negative comments, as you would expect, particularly around travel, the impact on HRI, the potential increased demand at the 2 sites where the service would move to, and also the risk was raised as well. And what we've done, we've gone through all those. I won't do those now, Chair, but we've gone through all those and responded to each of those in detail in the paper. As part of the consultation, we did ask for members as well of the public to put forward other suggestions as well that they could put forward, but they would be measured on the same criteria that we had measured the original criteria for. And just to remind members briefly of those, that it was we started this piece of work around meeting the service specification, the national service specification for specialised vascular services, where this piece of work started. And so that was the first criteria, whether any alternative would be able to meet that. And also, that links in with the support of the Clinical Senate, who supported not having the 3 centres across the area. It needed to stabilise the workforce position, ensure it had the right population size covered, provide a clear pathway for the ambulance service, support the co-location with the major trauma services, maintain the access with the dedicated renal inpatient services, and also look at the impact of the car and public transport. So some of those options that were fleshed out by other members that came forward were one around moving the renal services back to HRI, was making HRI one of the specialist centres instead of Bradford, was keeping all 3 centres, or even looking at another centre such as Airedale as another centre. And using those criteria, all those options are being discounted as being suitable to take forward. So where we are is that we will be taking forward a recommendation based on the original position in terms of moving to the 2 specialist vascular centres, one based at Leeds and also other at Bradford Royal Infirmary, due to that location of the renal services specifically and the population need. But with Colesdale and Huddersfield continuing to provide the vascular day case surgery, the diagnostics, outpatient appointments and the rehabilitation as before. But in terms of that feedback, there were some things that we wanted to consider and take forward as action going forward. So the 3 things we will be committing to now. One is around the requirement for the West Yorkshire Acute Trust to develop a regional solution around the non-vascular interventional radiology. And this is quite strongly in the conversations we've had around the concerns about sustainability of that service. And so we'll be ensuring that there is a robust plan put in place to look at a regional solution for that service. We'll be writing to the Bradford Trust Chief Exec to raise the concerns around the parking specifically, and also writing to transport authorities to inform them of the changes and the number of people this will affect. And also, as we go forward through the piece of work, we will be continuing engagement with vascular patients and ensuring we monitor their experience and measure that as we go forward. So, to conclude, Chair, we present the paper for your consideration, and also to ask if there's any other considerations or we'd like to take forward before we take this to a formal position and decision with NHS England. Thank you.
Can I just, before I open it for questions, can I just ask for some clarity, please, around your comments? The Clinical Senate said in January 2017 that the model outlined within the service specification of an arterial centre supported in a network arrangement with a non-arterial centre, and the working example of this arrangement in the West Yorkshire geography is between Leeds and Mid Yorkshire Trusts. And you've said there that you're talking about Wyatt putting in place that network. My question is, you've said it's out of scope of this consultation. My question is, if the Clinical Senate said you to work within a network arrangement, why have you said it's out of scope? Can you clarify that? Because we asked that last time, and I just want a clarity on that, please.
So I think what we're discussing is we're primarily discussing vascular services. What there is, and if you look at a number of the trusts in the region, there is a separation between vascular intervention, that being X-ray treatment of the blood vessels, and non-vascular interventions such as drainage of kidneys, gallbladders, abscesses, etc. Whereas within Calderdale and Huddersfield, it's the same group of radiologists who deliver both. So clearly treatment of gallbladders, blocked kidneys, etc. lies outside of a vascular process or vascular service. However, we do accept that there is that knock-on effect, which is why, and I can describe to you in more detail if you wish, we have already put a train of meetings and resolution in place to try and address that, although it lies outside of vascular because that treatment doesn't involve blood vessels.
Certainly, but as you said, in Calderdale and Huddersfield, it's the same person or people that are doing both. And so it has a very direct knock-on impact on those other areas of practice.
So just to clarify then, I'll get into the detail of that. It seems like a good point. The first thing is that obviously within the daytime, there will continue to be a daytime presence of an interventional radiologist at Calderdale and Huddersfield. So what we're describing is out of hours. What we know and just to rehearse what we heard last time is the frequency of those things. I think last time we met in Halifax, the clinical director of radiology quoted 12 kidney drainages out of hours in a whole year, and the clinical director for obstetrics and gynecology cited one episode in 10 years. What we're putting in place is, or what we're trying to get through in place is some regional clinical pathways that ensure that the safe treatment of these rare occurrences. How we're doing that is we've got that through our West Yorkshire Vascular Programme Board. It has been discussed at the WIAC committee in common with the chairs and chief executives. I've had an internal meeting with the Chief Operating Officer at Calderdale and Huddersfield, and what we've already got in place is a wider meeting on the 11th of March to actually flesh out how we would do that. And there is now an acceptance that because Calderdale and Huddersfield has that somewhat unique situation, that we now, and I say we as Calderdale and Huddersfield, need to lead on that piece of work within the region to create that sustainability and resilience for that rare occurrence and those patients to be treated. Again, to try and improve the workforce, we are currently out to advert for a joint post for Calderdale and Bradford for further interventional radiologists to try and recruit. And we've addressed this previously through that regional working.
My question goes back to why wasn't it part of the consultation? Because it is part of the service that needs to be put in place. You consulted on vascular services, but there's a wider impact. So why wasn't it part of the scope of the consultation so that people had full information? Surely you would have been further along the line with what a network would look like, so you would have been able to describe it in that consultation.
I think there's 2 points to make to that. The first is that the Senate report, which it's very helpful to read again, it supports the networked arrangement, and that refers to arterial centre networked arrangements, not specifically to the non-vascular interventional radiology service that's required. And secondly, we're not proposing to change how patients where patients will get their general interventional radiology service for. I mean, it's clearly highlighted that that needs to be tackled because of there is a shortage now of interventional radiologists, so it's not like it's a new problem. There's a problem in vascular already with interventional radiology availability at Colsdale and Huddersfield. It resulted in the service having to be closed over the summer, so it's a problem that exists. And you've highlighted the importance of making sure we have a robust interventional radiology solution as part of the reconfiguration, but it doesn't require consultation because we will have to find a solution to this problem as part of implementation.
And just to clarify that this is not a new change, because when, as you know, we have this alternating arrangement. So this alternating arrangement, so out of hours, this 50% of the time for the last 8 years or so, this has been the case. So this isn't a particular change that is going to occur because of the vascular site. This is just it'll happen more frequently, but that system and that reliance has already been dealt with.
Thanks, Chair. Excuse me. When you presented your case originally to the Senate, as outlined in that report back from them, did you not then need to include to them your plan that you've said here, which is basically it's outside of the scope? And this is why you don't think it's important that it should have been part of the consultation. And if you didn't, why didn't you? For them to have a comment on the whole issue. Because that letter there and the reply and the answers that you're given don't seem to marry somehow. If you have consulted the Senate, you've given a part of the picture, by the sounds of it, because you don't think it's within the scope. They've responded on that, but yet there are questions around it in terms of the capacity and the issues that are identified in this report about staffing, about the professionalism required, and yet that doesn't seem to be a part of the whole issue around this particular change that you're putting forward.
I think we reiterate that the consultation concerns the configuration of vascular services, which is proposed to... Which...
We know about the consultation. I'm asking questions of the two opinions of the Senate. David Rule has responded to now. We haven't seen, and I would like to see, or have seen before now, what you put forward to the Senate. Because then they came back saying you needed other things to be considered. So you didn't put forward to the Senate at that particular time evidence to say that this was outside of the scope.
Well, I mean, from a clinical perspective, and again, I'm not here to talk about the NHS England consultation process. I'm here to talk about from the clinical side. Sure.
Forgive me, we're going around the circles here. There's been two questions asked about the clinical Senate going back, and now the position's come forward. The question asked from the chair really hasn't been answered.
So, like I've said, this is a unique situation relevant to Calderdale and Huddersfield in terms of that interdependency between the on-call internal interventional vascular and non-vascular intervention, and I expect that that because it was unique to them, when you're doing a wider regional reconfiguration, there is an element of the individual trusts to sort out something that by definition is non-vascular, rather than that coming in into the remit of the vascular regional reconfiguration. So there is something around the individual responsibilities of the organisations and the individuals to deal with that. Even at this stage, what I would say is that we are taking this on to a certain degree and responding to it as a concern that has been raised and as a knock-on effect, but it lies outside of that responsibility. So I understand we're sort of getting stuck on this point, but we are facilitating it because of its knock-on impact rather than it primarily lying within a vascular. By definition, and what we're talking about is non-vascular intervention. So I understand I understand the discussion here, and we are happy to facilitate those discussions and be involved with those discussions and help with the resolution, but by definition it's non-vascular.
So the answer to that question, having gone around it again and again and again, is no, it was not mentioned that this particular situation was not clarified in your first letter to the Senate for them to come back. So it wasn't clarified in the first letter to the Senate for them to actually come back with their views?
So again, I'm here representing the clinical side. I'm not involved with the NHS England responses either to JOSC, other than sort of feeding into that, or to the Senate at that stage.
Well,
so
maybe we could hear from NHS
Yeah.
England then.
So I think that where we are with this is that there's a local challenge for that non-interventional radiology service, which we have. It's been consistent through the conversations we've had with members across, and I think what Neeraj has described is a robust plan about how they're going to go forward to deal with that. In terms of the consultation and the Senate, then this is really out with where it is, because that problem exists anyway. And that problem is not related to whether you have 2, 3, 4, 1 specialist arteriovascular centres. This is a problem that exists in West Yorkshire that has to be dealt with anyway. So from our perspective, that's why we wouldn't include that specifically in that consultation piece, because it's not actually relevant to the change that we're describing, because the problem is being worked through as an issue anyway.
Thank you, Chair. Can I talk about, I'd like to talk about Yorkshire Ambulance Service. And I appreciate that they sent us a supporting letter, and that this situation will be much clearer for them to just go, instead of the 50% 1 week, and that the situation they've got now where it must be confusing as to where to go. So I appreciate that. What I'd like to talk about is repatriation, because this is not the only service change. And we've had a number, and probably will have more. And it was raised in your document about people waiting for repatriation. And based on past experience of stroke services, there was concern amongst those, some who attended, that patients would face lengthy delays when waiting to be transferred. I appreciate in your response that if they were having ongoing surgical care, they would not be moved. But I would imagine that if you've had any kind of vascular surgery, you're not the wellest of, people, that you are going to be poorly, that you are, and that delays coupled. So it mentions stroke there, but we've had other service changes that depend on repatriation to a local hospital. It's Yorkshire Ambulance Service, so it's not just West Yorkshire and Harrogate. So basically my question is, what is the tipping point for Yorkshire Ambulance Service, please?
Well, we can't speak for Yorkshire Ambulance Service, as you'd appreciate, Chair, but we've had confirmation from them that this change would actually be helpful for them, because at the moment they're running an alternate week, and that's not helpful, and it's much better to have a clear pathway for people when they are in crisis for that. So in terms of the emergency side, then Yaz have confirmed they're comfortable with that. I think part of the implementation going forward is around, it's really important that repatriation is right. I fully support what you said, because people need to be back home. If they are in a longer term rehabilitation after a major operation, then we would want them to be back home close to where they can be, where it's safe to manage them, so they can get the rehabilitation support from their families as well. So part of the piece we'll be working with Wyatt is around that repatriation piece, and saying, that criteria that needs to be in place that all the trusts will be signing up to, in terms of making sure people aren't stuck in the wrong place. Is there anything?
Yeah, so we have formed a clinical working group. We have 3 streams, which is the clinical working model pathways, to ensure that wherever a patient comes into contact with our service, whichever part of the geography, they get the same standard of care and the same pathway of care. And the final one of those three working streams is repatriation. The aim would be that primarily we would aim to discharge people home. We're aware of those cohorts of people who can't do that, which are the elderly, the post-amputee patients. Within that group within that clinical working group, there is representation so far from 2 Yorkshire senior people within Yorkshire Ambulance Service who are contributing to that planning. We also have a number of therapists, prosthetic rehabilitation therapists who are forming that pathway and that plan. The primary aim is to discharge home, so Yorkshire Ambulance Service won't be involved. There will be community rehabilitation as well, and then there will be a facet of repatriation back to another hospital. That obviously would not be an emergency, so that wouldn't be priority, so it wouldn't impact on the emergency provision of the Yorkshire Ambulance Service, because these will be planned repatriations. So it shouldn't impact on the sort of blue light response, if you see what I mean, because they wouldn't be priority cases. And the other thing is learning from other models, like, as you will know, locally in Leeds, that, you know, the major trauma model, and there are memorandums of understanding that around the repatriation model with trauma locally that we're learning from, so we can try and minimise any impact. We've talked about how therapy is creating a sort of passport that gets over that council boundary assessment issue about needing wheelchairs and etc. So that we're very conscious of that. There is a lot of work being done around that to try and minimise any impact on Yorkshire Ambulance Service, and actually to try and bring people back into the community in their own home quicker than we can at the moment.
Thank you. If I could just come back really, I totally understand that it won't impact on the blue light service. Having, been in, especially with the elderly, and waiting for transport, and it might not be Yorkshire Ambulance Service that's providing this, it might be private and or the hospital's own. It can be very, very, so that to ensure repatriation is timely, I think is a crucial thing that if they are booked at a certain time, that it happens as close to that, because it's incredibly frustrating for people on the other end waiting for them, and for the patient themselves and families involved as well, and it can't be good for anybody's well-being. I'll bring the wider issues about Yorkshire Ambulance Service at another time when we've maybe got them here. Thank you, Chair.
Thank you. At our last meeting, we spent quite a long time talking about training, and the fact that we're in this situation, both for the vascular and the non-vascular interventional radiology, because of an inadequate number of suitably trained staff available to be employed in this area. On page 16 in the report on the consultation, that's 16 on the agenda numbering, it says the proposals are driven by the need to maintain high quality clinical services, not to save money. And I think from what we've heard, we can agree that the proposals aren't to save NHS England any money, but there's no explicit recognition here that these are largely being driven by staff shortages of appropriately trained staff. And unless there's an acceptance and acknowledgement that that's the case, then there will be very little motivation to actually do something about it. It's regrettable, although we've invited them, that we've had no evidence from Health Education England, who have the responsibility for training programs. If we go on to page 20 of the report, it says, whilst there are national recruitment drives and training initiatives in progress to address shortages, there remain challenges in the workforce. When we asked explicitly about training initiatives last time, we were told that any change in training numbers in Yorkshire have been minimal. So, if I would like to know what is being done, if not at Yorkshire level, at national level, to address the shortages of appropriately trained staff to provide these services in the future, from now and into the future, because otherwise I can quite foresee in a couple of years' time that we won't have the staff to be able to run a centre in Bradford either, and we'll be looking at consultations on coming to one centre in the whole of West Yorkshire.
I suppose there's two aspects to it. The reconfiguration is being driven to deliver the specification, which is based on a key part of that is activity, the number of patients served, because that is associated with better outcomes. So that is kind of a really important driver. That is the specification highlights the evidence around the numbers and the size and scale of a service to get the outcomes that you need. That is linked, of course, to the availability of staff and the staff willingness to work in a service. So you've raised the supply of interventional radiologists, which is a nationwide issue. It's known to Health Education England. At that point, it's really difficult for us to make further comment because Health Education England are the body that determine the training places and where they take place and so on, and they're fully aware of the problems, and we've highlighted those to them. But it's their decision about how they go about allocating their resources that they have available for training to deliver the staff that the health service needs. And I can't really go any further than that.
And we invited them to come and speak to us here, and it's regrettable that they haven't.
That was my question. But in addition to that, we learnt last time that there is not a great deal of interest in in newly trained doctors, surgeons, whatever, in working the sort of hours that you were quoting you worked last time. And to support the service, those hours have to be worked. So if we haven't got the people coming through, and the ones that are coming through only want to work Monday and Tuesday and then do something else, it's not going to be a sustainable service, is it?
I think what we're trying to do is through this create a different working model. So what, for example, this would allow us to do is currently how we say I deliver my on-call is that I'm on call whilst I am still doing clinic and whilst I am still operating. I will deliver a 24-hour on-call, and then as part of my normal working week, I will deliver a 72-hour on-call, having done a normal working week, and then do a normal working week the other side. Because we can, by consolidating numbers, what we can create is a consultant of the week model, which will mean that one consultant is on call every day for a long day, 8 a.m. to 8 p.m. or around that time, and they are dedicated to just providing that emergency service. So therefore, it reduces that intensity of work, but actually more importantly for the patients is that if someone comes in, there's someone available to respond to them immediately, rather than either me having to cancel my clinic and the 20 patients in my clinic and go and respond to it, or the patient who's been brought in having to wait till I finished an operation. So because of the new working models that we'll be able to implement with the greater pool in one place, we would actually be able to change what we do to make it better for the patients and more attractive for people and more sustainable and into the future.
I was just going to add, I think the shortage in many areas of healthcare of staff, not just here but around the world, it is the world as it is, and it is frustrating that sometimes the supply of trained staff is less than one would think is desirable. But living in the world as it is, our job is to try and make sure that the service that we can offer to the people who live here and round here is attractive for good staff to want to come and work in and stay working in. And part of the attractiveness of consolidating the service is that, as Neeraj has explained, it becomes a more attractive place where people want to work. So although there is a shortage, I'd be delighted if we get the staff around here that we need, because that's important for people around here and our responsibilities for people around here. So that is an important part of what this we think will achieve.
And yeah, just to pick up on that, what we would be able to do is, because at the moment, say for example, with 4 of the surgeons, and I'll talk about the surgery side rather than the interventional radiology for a second, because that's what I do. So we've got 4 surgeons here, and then we've got a greater, and there's 5 in Bradford. Actually, what it'll allow us to do is subspecialise as well. So at the moment, we're doing everything. And again, I'll come back to this, and I was grateful to Councillor Hutchinson that we are providing clinical outcomes that are better than the national average, but that's not sustainable. And what we can do moving forward with development of technology is actually embrace that, and people, because you've got that bigger pool, you've got better governance, you can subspecialise, and you can actually drive things forward, where when there's a more limited pool who are just, you know, keeping the show on the road, if you want to use that terminology, you don't necessarily have the space to take on the skill set to take on those developments where you've got more people in a service that you are actually able to do that.
Yes, some of the issues have been covered. I just want to comment on one or two. First of all, the issue about repatriation is not about the ambulance service. It's because you won't be able to repatriate patients to beds which have already been filled with somebody else. And I suspect that's the real issue with repatriation. You get them to Bradford or Leeds, and there isn't a bed available in Huddersfield or Halifax or Airedale to put them in because it's being filled with an emergency patient. And that'll be particularly true in the winter. And I suspect that is a big issue, and particularly if that receiving trust wants you to prove that they don't have MRSA and all the rest of the pangendrum. That's just a comment. The second thing I wanted to talk about was the specification issue. Now, I mean, we keep coming up with specifications that we do not have the staff to fulfill. And you can go whatever medical subject you want. You can pathology, radiology, surgery, obstetrics. We invent a specification or a college requirement that requires at least 3 times the number of people that we actually have. You think, well, why doesn't someone tell them there's no point in that? Instead of which, it then creates an opportunity for people to work in the place which can meet it, which always amazingly is Leeds in our region, and sometimes York. But it's never going to be Huddersfield or Airedale or Halifax or Hull or Scunthorpe, because they're not nice places to work, are they? They are, but they don't sound like it. So what is the point in coming up with a specification which will, by and large, not be met? It would be better to come up with one that does. And just to comment on that, there were 33 years warning that there would need to be a replacement for me in my job, and I still didn't have a replacement ready for me when I retired, which is a dismal reflection of all the money I paid into my Royal College to undergo that training. And that epitomises the reality. So instead of plan A, which we train doctors, which we're not going to, or have all these 6,000 new GPs, which is not going to happen, why don't we come up with a plan which might be fulfilled? Something like training other people or requiring less or fewer people to run our services, rather than coming up with a specification which says we've got to have 31 interventional radiologists in Leeds and the rest of you can go begging, and which is, an over-exaggeration. But that's the problem with these specifications. Whatever field of medicine you touch, you come up with a specification which is not being fulfilled for most places, and they're always seen in this way, which are, I know the purpose, but it's overall a bit of a daft way forward.
I'll just kick off about the specification. Thank you. In terms of the specifications, I think the other side of that is the benefit of having a national specification, because prior to NHS England taking on specialised commissioning in 2012 with the Health and Social Care Act, then specialised commissioning was part of local systems. And so what you had was a significant variation, not only in the quality of care, but also the access that people had across the country. So in terms of the specialised care, which is just the top end of the pathway, remember, the majority of care is commissioned by the CCGs and managed locally. Then for the top end of that care, it is right that we uphold the highest standards that we have, and there's a uniform standard that's done across the country is the right place to start. And to get to that specification, then, there's a significant amount of work that goes on with experts across the country, across the world, that input into that to ensure we have a high standard of care that we expect to have, really.
Well, I'm involved in the national work on the development of specialised commissioning specifications, and in a way I've got sympathy with some of the points that you make, because they're very much in my mind when the specifications for the whole range of specialised services come through the committee that I'm a member of, and a big part of our job is to make sure the specifications are reasonable and achievable and balanced. And it is the case that we look at recommendations from Royal Colleges and so on, and we don't necessarily implement those because they are sometimes overplayed. In terms of this specification, I actually think it is a reasonable specification. It's really based on the number of procedures that need to be carried out in a centre to get the best sort of outcomes. If you carry out that number of procedures, then it begins to indicate how many staff that you need. And I think in this specification, it's six surgeons. I mean, that's, to my mind, 6 surgeons working to cover 24 hours a day, every day of the year, and with the number of procedures specified is actually not unreasonable. I don't think people want to be doing any more on call than 1 in 6. It's still quite a lot of time. I know things have changed. Obviously, when I started my medical career, I did a 1 in 2. You probably lived one. You did a 1 in 1. But nowadays, people won't do it, and actually, the demands of healthcare are such that it's too technical. It's not possible to provide good quality care if you're on call too frequent and the hours you work are too great. So I think this specification is really driven by numbers of procedures and therefore population that needs to be served. And linked to that is some staffing levels, which actually, to my mind, aren't unreasonable. I'm sure Neeraj would have a comment if he thought so. And quite interestingly, I've been visiting the specialised vascular centres around Yorkshire, the whole of Yorkshire and Humber. I haven't been to Hull yet, which is specification compliant and does. So please, I'm really a fan of Hull because that population need good care, and we bend over backwards to try and make sure that Hull retains its specialised services because they're so geographically far away. And sitting with the Getting It Right First Time visiting team, visiting each of the specialised vascular centres, they do meet the specification. They do just about manage to have 6 surgeons, often no more than 6. And they do have managed to attract and retain the number of interventional radiologists they need when they're of that scale. And everyone's pretty busy. So I don't think we're being too profligate in this specification. There have been specifications where I don't feel quite the same, and there are specifications still in the system for other things where me and colleagues are still pushing back. They haven't been approved because we're pushing back on the requirements. Are these excessive? Can they be delivered? No point specifying something that you can't deliver. That becomes a futile exercise in wasting everyone's time. But I think this can be delivered, and I think it is right. I mean, actually support it. I don't have those qualms about this, but I generally accept your comments and that we need to be really careful.
Can I just add a clinical side to that? In terms of, so just to frame what we're discussing here, this is a national process. This isn't something that we're doing just between Bradford and Huddersfield or Leeds and Mid Yorks. This is something that's happened nationally. So we have learned from the other networks. So we've been in touch with the South East Vascular Network, which has been configured to cover 3.4 million people population out of one arterial centre. Bristol, Bath and Weston, which covers about 1.6, 1.2 million, and Brighton, similar numbers. And what we've learned from them is the importance of those other roles as you've described. So yes, we are exploring other people developing those roles, such as advanced care practitioners, which there already are in Bradford and Leeds, and the importance of the vascular specialist nurses, who we already have within the system. In terms of could you deal with it with fewer people, clearly the demand is rising. The main risk factors, as you know, are diabetes, high cholesterol and hypertension, all of which are on the rise. So I don't think putting fewer people into a increasingly demanded service is going to resolve this. Hull is an excellent centre, and I think again it was like it's sort of harking back to the comment we had at the last about only getting good at the last meeting, where you only get good outcomes if you sort of live in LS1 or LS8 or whatever the comment was. I think talking about people not wanting to work in Hull again provides excellent service, and having trained in that area, I think just for a point of fairness, it's just important to point out what an excellent service they deliver.
I think so, but if we want to concentrate on this. I do think, though, that there is a slight contradiction here in that you are making these changes because of the national standards and understand the national specification. But part of your argument for locally changing it is there are staff shortages and there's not enough. And yet your report says that this change, the workforce will increase because of this change. And I find that contradictory. There is a part on workforce in your report that actually says the workforce says it will be increased. So I find it contradictory.
So it's about changing those models that I described earlier that make actually, because you can have a bigger pool of people, it gives us the opportunity to do things differently. And by doing things differently, it improves that recruitment and retention. And so the example of that, and again, I won't go through it again, is that consultant of the week model, whereas when you're on call, you're just on call. You're not on call whilst you're also in clinic or also operating. The fact that instead of having because you've got exposure to more cases and more organisations, you can develop subspecialist interests. So whereas people may not come now because they're going to be on call for a whole week at a time and are limited to the procedures delivered within that organisation, what we can do now is say, actually, you're not going to be on call 24/7 for 7 days because you're part of a bigger pool. Your on-call will be less intensive, but also you can now gain exposure to these other procedures that are done in other places that you didn't have access to because you're only working within the one organisation, that can satisfy career aspiration. Outside of the medical workforce, it allows the nursing workforce to have clear exposure to different procedures, different skills, rotation to see how things are done differently, and also a clearer training pathway if they want to proceed to something like a vascular specialist nurse or a nurse consultant or an advanced care practitioner, which when you're working in one organisation, there isn't necessarily the funding or the capacity to do. So we feel by increasing the pool, increasing the complexity of the work you can be exposed to, that will actually help with recruitment and retention.
I do think it's a little bit my comment is on this because generally across healthcare, the number of staff employed in healthcare rises over time. As the population ages, we can do more and so on. And this is, I think if we said we were going to have less staff, you'd be rightly questioning is how we could have less staff when we might expect the ageing population to kind of require more services. It's good that we've got an ambition for more staff, and it's kind of good that we think the configuration will enable us to better secure the staff. So I mean, I think it's a good thing that it says that. I understand the question, but I don't think it's a contradiction, is where I'm disagreeing.
Can we move on to modelling of beds? Because you talked about repatriation and having a protocol in place, etc., for repatriation. And you're talking about modelling extra beds at theatre and interventional radiology capacity. And that was part of the implementation phase. Can you answer the point then about beds across West Yorkshire? Are you modelling just the Bradford's and Leeds site bed capacity, or are you modelling bed capacity across the board to help with those repatriations as well?
So, as you've suggested, we're modelling across the board. I referred to the meeting we've got on the 11th of March that within Calderdale and Huddersfield with the Chief Operating Officer and the relevant clinical directors and general managers of all the services, that part of that discussion is also to involve the repatriation beds that will be required, where they come to, who looks after them, the physical estate space, and sort of complementary to that, there is a Bradford operations and implementation group that are also looking at estates capacity and so on as well. So the simple answer is yes, we're looking at it across the region, not just solely in the arterial centres.
Thank you. I do have concerns regarding how robust the modelling of beds is and of theatre capacity in BRI. I mean, the kind of cases we're talking about are severe people with severe problems that need surgery pretty well immediately, if you're talking about ruptured abdominal aortic aneurysms or somebody with an ischemic leg. And so there needs to be the capacity to respond immediately to any peaks in demand. And the descriptions here are all about looking at this and looking at that rather than sort of a clear understanding of how those peaks in demand can actually be accommodated within the estate at BRI. And particularly, as we've said, where the population demographics suggest that the demand will be increasing rather than decreasing with time. So,
the reason it's been described as such at that point is because we were in a consultation phase, and given the pressures, operational pressures within all trusts, going back 18 months to start modelling it with that level of detail would have been quite a significant undertaking. But we are absolutely into that level of detail now. We know that we have 7 sessions worth of, like you said, it is I would say, urgent specialty rather than emergency specialty, and that's how GERF describe it as well, with 70% of our work being urgent, and what that means is within sort of 72, 24 hours rather than immediately. We're aware of the numbers of theatre sessions and interventional radiology sessions that will need to move across, which is 7 from CHFT in terms of theatre and 3 sessions in terms of interventional radiology. And we also have the numbers, the exact numbers of out-of-hours operations that are done at Calderdale and Huddersfield. So we're looking at work, and we are working with the directors and managers of theatres within Bradford to see how that will impact on the acute theatres and any other specialties there may be. So I understand your point of how it has been referred to in the documentation to press, but I can reassure you that we're actually very much into numbers of sessions, numbers of staff, and exact numbers of procedures as well.
Because I have heard concerns from senior members of staff at CHFT about the capacity at Bradford for coping with the not just the vascular but also the non-vascular that will be impacted by the change of staffing pattern. Particularly for, going back to the interventional radiology side of things, that they're not convinced that there is the capacity there at Bradford, or that there will be, to actually cope with the patients that require those treatments.
So again, coming back to the fact that we're changing the working models. We are, in terms of capacity, what we're having is different pathways. So, for example, currently if someone has critical limb ischemia, because of the pathway, what we do is we admit them into the hospital they stay in hospital for a period of time awaiting a scan, then awaiting to go on a list. What we are creating it now is a virtual ward so they can have an expedited outpatient pathway. So their imaging is tracked through a virtual ward coordinator. So actually what we're being stimulated to do is look at and implement and invest in these different ways of working. So actually, it's not going to be the whole cohort that we have now transferring across because of the different ways that we can work. And very much we're working with Bradford directly. At the moment, what we are planning is at least weekly calls and monthly operational meetings to ensure that there is that capacity, how it's created. And we had, at the end of last month, a meeting of the consultant surgeons from both sides, and there is we would not move a service until the situation is such that the capacity is there and the patients are going to be treated safely. We're proud of those outcomes you described, and we don't want those compromised by moving a service until we know that there is a capacity, we can get into theatre, and there's enough space on the ward for them.
And just to clarify, Chair, we are finished consultation. We have now we've come to a recommendation, but not a decision has not been made at this point. So in terms of the work going on, there's some really good work going on in terms of a network approach, which we support anyway. But the decision in terms of this has not been made at this point by NHS England.
Can I come back to a point? Because national specification and good outcomes for patients. Fully understand that, right? But you've got two Royal Colleges that are saying to you, interventional radiologists carry out a range of other services and procedures in addition to vascular interventions, and a failure to keep this in mind during the reorganisation could result in significant threats to patient care. The other one says, any change to the spoke hospitals should take into account the potential consequences of leaving these centres without cover for these life-saving non-vascular interventions, right? So, I come back to the point, and to me, NHS England has got this reorganisation that's doing across the country on vascular services, but that local solutions should be discussed locally as part of the discussions about how you're going to keep patients safe across both vascular and non-vascular interventions going forward, and how that affects the sustainability of services in West Yorkshire moving forward. And the gentleman from Wyatt, we haven't heard from yourself, so do you want to comment on this at all, please? Because I would like to understand why NHS England and Wyatt have not put, as part of these proposals, have not put a proposal together for the whole service, as I would see it, because we have a situation at the moment, do we not, where, as you said, over the summer there were problems with the service as it stands.
So I think the point is that the change is going to be to the service offered to vascular patients and where they get their service. What we need to do is mitigate the consequences of that, so there is no change to the service that non-vascular interventional radiology patients get. And that's what Neeraj has described about how we will go about doing that. The point that the colleges make about not understanding the impacts of this, during the daytime, there will continue to be the same service in Calderdale and Huddersfield as there is at the moment, so there will be no impact there. Out of hours, the numbers of patients are very small. One obs and gynae patient in, I think, 10 years, 12 years, effectively one patient a month in urology. And we think we can put in a service, looking at it regionally, that will maintain that care for those patients. So that's why it's not directly part of the consultation, because we're not expecting it to change for those patients.
So, thank you. I mean, just as going back briefly to this, networks certainly have advantages, but so do smaller, close-knit teams working in familiar environments where people know the capabilities of the people that they're working with, particularly but in theatre, but not just in theatre. And so it's something, you know, networks can help cope with fluctuations in staff levels if somebody leaves or can't work for a period of time. But there's very little that will beat people working in teams where they all know each other intimately and you don't have to explain yourself. So many things don't need to be said, and you know where all the equipment is kept and stuff like that. So I think that's something that needs to be borne in mind when people look at the actual working environment. But I'd really like to know about, have a clearer idea of the plan for dealing with vascular emergencies at the non-arterial sites. The response we got, which is on page 10 of the agenda, was that that there'll be a vascular nurse specialist on site, not necessarily a vascular surgeon. And these, although they have, you know, they can complement each other very well, they're not exactly the same. And if the intention is to substitute vascular nurse specialists for vascular surgeons for providing on-site services at the non-arterial site, I would be rather unhappy about that. And I'd also like to know clarity as to how to maintain the equipment and staff expertise at the non-arterial site to cope with arterial emergencies should the need arise and should the patient be too unwell to be transferred over. It's fine having a vascular surgeon come from the network to try and sort things out. But if you haven't got the equipment on site, because there isn't often, arterial surgery isn't necessarily being done very frequently, and if you have nursing staff who've got, theatre nursing staff who've got very little experience of dealing with arterial surgery, they're going to have the Swiss cheese effect starts to kick in. Of having too many problems and the outcome may be not so good. So it's how do you actually maintain the presence of the appropriate equipment and staff who are appropriately trained in managing arterial cases on a site where arterial surgery is not taking place?
So it's a really interesting question, because after we met, we discussed this on the 17th of January when we met, and it was only that evening, having had the conversation and reassured you how we deal with it, that I ended up driving to Airedale at 11 o'clock at night that evening. And so just to refer to that experience itself, Airedale, who have not had arterial surgery for a good number of years, I would say at least 8 years, hold an arterial emergency stock, which they review. The scenario was that someone was was doing a general surgery operation that had an arterial or venous complication. I drove across to Airedale that night. The kit was ready. When I got there, it went very well. And there is that acceptance that we will have to travel in those situations. The same applies to Calderdale, where I think it was 2011 or 12, but actually possibly before that, well before that, that the arterial moved to Huddersfield. At Calderdale, there is an arterial tray to arterial equipment that is kept in theatres. And I must say, as you well know, Councillor Hutchinson, there is a basic skill set of the theatre nurses who are very experienced in everything else, where in that situation they can deal with it, and did deal with it within Airedale for that event I had to respond to. So the equipment is kept locally and refreshed. Coming back to your point about the daytime activity, we're not suggesting that vascular surgeons will be replaced by vascular specialist nurses. Vascular specialist nurses will be there to be able to respond to things like the inpatient reviews. If someone's reviewed with a gangrenous toe, if someone's referred with an ulcer, the vascular specialist nurses can respond to that. They can also run the admission avoidance clinics where GPs are wanting an urgent but not emergency opinion. So that will be the role that the vascular specialist nurses play. The provision of vascular services document states that there will be within each trust a vascular surgeon available to provide daytime emergency cover. As we spoke about before, if orthopaedics hit something with a drill, if the urologist, when taking out a kidney, or someone nicks something from general surgery with a trocar, there will be people on site to respond to that in working hours. Outside of working hours, it would be the same cover that we provide at the moment, the same cover we provide on an alternating week basis, the same that Mid Yorks gets from Leeds, and the same that we see across the country with all the other arterial networks.
Could I just add to that? I think it's worth remembering what the medical director from Mid Yorks said when she was here last time about having reviewed all the incidents that they'd had in Mid Yorkshire since the change that they'd had. And I didn't find that there were no serious incidents related to the provision of vascular surgery at Mid Yorkshire since that time. So that cover can be done and can be provided in a safe way.
But I do think that it would be worth looking at how you actually maintain the competence of your theatre staff to be able to respond if and when such a thing occurs, rather than just hoping that whoever happens to be there has had some experience at some point in the not too distant past, so that that the equipment trays are kept in stock just in case.
Sorry, Councillor Head. Sorry to. I've got a couple of points. I've got a point and a question. I very much welcome the change in modelling of working practices, if and when moved to BRI. I don't think we should expect our medical staff to do the kind of hours that traditionally have been done and that working. I was told with the injury to my face by my brilliant consultant that to take out some scar tissue, that if an emergency came in, he'd have to cancel my operation. I think that model of working. So I went private because you don't have that conflict. So I think, and it's not just about recruitment issues for me, it's about the well-being of the current medical staff. I don't know how you do it. I mean, it seems unfair to have that expectation to work that way. No human being should have to work like that. Bit of a question, and I don't know whether you can answer it or not. When you were doing the consultation, it says the older age groups, those aged 75 and over, showed the greatest support for the proposal, and those aged 31 to 35 years, the least support. I just think it's a really interesting statistic, and I don't know whether anybody's had any conversations with people from their age group, because I've looked in the papers and it's not clear to me why they might have less support in the younger age group than the older.
We're just seeing if we have got a view on that one.
No, it's probably that the patients were from the older demographics, and then the younger demographics will have had less experience of the service.
Okay.
I mean, just to support that, the fact is that arterial disease is more common in older people, and actually the younger people who engage with our service in general are those who have varicose vein surgery. And just to be clear, that as part of this proposal, varicose vein surgery will stay local.
2 points, if I may, Chair. First of all, on the consultation, out of the population of the areas concerned, do I understand that the responses that you got was just over 370? Is that correct?
385.
Okay, all right. What would you have expected as a response? What percentage would you have expected as a response from the population concerned with this?
Well, it's always difficult to give a number of what percentage would be, really.
We've been in consultation before.
I think the challenge we've got with these services are they're very specialised services, and so the people that will have accessed them will be a very small number of people that we've had. So I think what we tried to do with the engagement events was to reach out into the clinics with the renal patients, etc., writing out to 1,000 patients just to focus on those areas as much as we could.
Okay. Follow on, if I may. So really there would be part of the population then that would have been considered suitable for this consultation. I mean, you've got carers, you've got people, ageing population, who may need it in the future. So it's been confined to a certain group of people, has it?
No, not at all. No, I think we've advertised this widely. It's been on websites, it's been media releases, there's been BBC News. We've had two pieces on there. We wrote out to the vascular people because they're the people that have actually been through the service.
I appreciate that. I'm not about the wider population who may need the service.
Well, yeah, we advertised it widely. We advertised it widely as we could, really. Yeah.
I think.
I'm sorry, can I just continue? Yeah, I appreciate you want to come in.
I don't particularly. I was going to direct the question to my colleague because she's.
I'm going to direct a question there as well. Thank you.
Okay, thank you.
It seems a very low number of expected. I would say it's a very low percentage in terms of the population as a whole, rather than it being confined to a certain type or degree of patient, either that have received the service or may be in line to get the service. In fact, when we've had consultations before in terms of numbers, there has always been an expected percentage. It's never hit it, mind you, but it's always been an expected percentage that's been said. We'd expect this kind of return. Secondly, I want to come back to something else that my colleague here said about it and the situation in here where it actually says, and you've mentioned, about people being sent back to their local hospitals. And Wyatt, I'm sure, been part of some conversation in terms of this. What's been the view of the trusts as a whole across West Yorkshire? Because we're speaking about West Yorkshire now. What's been the response as a whole about the position of having beds available? Because this was not answered to my colleague down here. We all know across our trusts the demands that are on beds, and particularly in terms of elderly care and social services being involved, as well as all the other issues. What kind of response have you had from the trusts of their ability to be able to have beds, as this report seems to say, you know, they're going to be just stood there waiting for people? And the other part of the conversation went on to say about people getting people back home as quickly as possible, which is good for the patient. But obviously the back home then means that there could be the need for some medical or social care support at home. So what kind of packages have you looked at in terms of that proposal, out of hospital to a local hospital? Who's going to hold the beds? Are there going to be beds on hold? We know that they're not waiting there as it stands at the moment for somebody to say, you're going to Wakefield, you're going to Leeds, you're going wherever. And we also know the demand that there is if that doesn't happen and the patient has to go home. We also know the demands that there are in terms of district nursing, and on top of that, any kind of social care that may be needed for that person while they're at home, rather than being expected to go to a hospital bed. So what kind of discussions had you had over the patch?
So we have discussed it with all the hospitals in West Yorkshire, all six trusts. They all recognise that is a better model of care that they want to move towards.
I know the model of care. We're not disputing the model of care. I'm asking the question, what answers have you had about the ability to have beds available? My colleague asked it, I'm asking it. What discussions, what answers have you had from the trusts on a West Yorkshire basis to actually suffice that information to be something to be part of a plan?
So between Leeds and Mid Yorkshire, it's already what happens to some extent. We want to make.
Mid Yorkshire, forgive me.
Can I finish the answer?
No. You've said across West Yorkshire. I know what happens in Mid Yorkshire.
Well, that's part of
Come across West Yorkshire and all the hospitals that are expecting people to go back to these beds across West Yorkshire. What has been the response from across West Yorkshire trusts?
Sorry, can I clarify then? When you say West Yorkshire, which do you mean Airedale, Bradford and Calderdale and Huddersfield?
I mean all the
Or do you
hospitals
mean-
that you're expecting patients to go back to their own hospital.
So that's part. So Leeds and Mid Yorkshire are part of West Yorkshire.
Absolutely.
So I'm just explaining that that's
All of
already
them.
what happens in that patch. They want to improve that and do more of it. We have protocols and agreements between the hospitals to enable those patients to move back. But you're absolutely right. The reality is no hospital is in a position to hold beds empty on the off chance that a patient might need to be repatriated to them. The hospitals have to manage that process and create and find the bed spaces as they need them. That's the conversation we've been having between Airedale, Bradford and Calderdale and Huddersfield about how that would work in practice. The reality is at the moment we have those beds. They're in Bradford and they're in Calderdale and Huddersfield and they're in Airedale. The question is whether they are redistributed in order to allow patients to be repatriated and to have more patients having their treatment in Bradford. So we're not creating new beds, we're just using them in different ways. And we have to, there is work to do to work out exactly how that works. That's absolutely right. But as you say, we haven't made a decision yet. NHS England haven't made their final decision. So the response has been positive, that that's what we want to do, and we will work our way towards doing that, and we think we're capable and there's capacity to do it. The exact way we're going to do it yet, we haven't worked our way through.
So just coming on from that, the trusts are very aware that there has to be that capacity to repatriate, because if you can't repatriate, as you've suggested, the acute arterial centres will become saturated with patients waiting to go. You therefore can't get the emergency and urgent cases in. So there is an absolute acceptance, understanding that there has to be that ability to enable that patient flow throughout the whole of West Yorkshire, so the arterial centre can function effectively. In terms of who cares for them was one of your other questions. That's something we're learning from the other networks. In terms of the networks, I said around the country, and including places like Newcastle that we're speaking to look about how they do repatriation and have been doing for years sort of safely across the country. I don't necessarily see that the district nursing requirement would change. And the reason I say that is because the requirement would be the same irrelevant of which hospital they're discharged from. So I don't see that discharging a patient from Bradford who has a wound is any different to discharging them from Airedale with a wound. It's so the district, the capacity or the demand or activity won't change because of the in-hospital secondary care configuration, if you see what I mean. We are meeting with the Director of Community Services within Calderdale and Huddersfield to talk about these issues that you've described. So very much we are exploring that. And again, looking at other models, even locally, like trauma, where there is that repatriation model and learning from them. So it happens within the region with trauma services, it happens within the region with specialist cancer surgery. So this is just another service with which we're, replicating other models and even learning from outside of our current locality.
Can I just come in on the wellbeing side of repatriation? Because if somebody is in the specialist centre for any length of time, either because they medically need to be there or they can't be repatriated, it is essential, isn't it, that people are able to visit so that they can have family and friends visit for well-being. It's part of feeling better, isn't it? When you're in hospital, having people visit you. And one of the things you've put in your feedback, there's a number of series of actions. You've got 3 actions, and one of them is a commitment to write to Bradford Teaching Hospitals to share details of the parking concerns raised by respondents. So I understand that NHS England doesn't have any authority on Bradford Teaching Hospitals to put in extra parking. However, you're increasing a specialist service that will move to 2 centres. So you're going to write to Bradford Teaching Hospitals. Why hasn't there been more discussions about, when you're modelling on beds and you're modelling on everything else, why you're not modelling on capacity for people to be able to park or get transport to the hospital? Now, I understand day cases and everything else will stay as they are. So you're just talking about the acute side of this. But I have mystery shopped BRI, with all due respect to BRI. I have mystery shopped BRI, and certain times of days it is very, very difficult to get parking spaces, like any trust that we have now. Pinderfields is the same. Leeds hospitals are the same. They're awful. You can't. So rather than just writing a letter, does Wyatt have any discussions on how people can actually get to people who are in these acute settings? Because this isn't in isolation, is it? There are other acute services as well.
So I come back to the point that Wyatt is not an organisation in itself; it is the trusts. So it's not, and car parking is something which all the trusts are dealing with individually. It's not something that we're working on as a joint thing across Wyatt. So I'm afraid there isn't something that I can comment on specifically.
Yes, obviously this is one of my favourite topics because of the clientele involved. I mean, today, to get to Huddersfield, because I couldn't drive, I had to travel into Leeds on the train and then out to Huddersfield, having had a 2-mile walk from my home into the centre of Keighley. Now, I'm not telling you that for the sake of sympathy, but that's the sort of journey that people undertake. So someone who would normally have gone to Huddersfield will have to go into Huddersfield, catch a train into Leeds or whatever, then catch a bus across from the Leeds station out to St James's, or a taxi. So it's quite a formidable journey if you can't drive, and it's even more formidable if you do drive it, as you probably know. So what thoughts have been given to the people supporting the patients, for example, providing a minibus service from the Huddersfield site maybe to BRI, and picking up the folk from Halifax en route. And that would be something that could be applied to lots of services, which would be a real boon for patients. Has that been discussed with the mandarins at BRI or anything like that?
I think that parking and transport to hospitals is a real challenge across a lot of hospitals, and I think it's not as simple as you'll know, it's not as simple as saying, I'll just build more car parking, because there's huge environmental issues and there's targets that hospitals have in terms of helping the environment as well as helping access, and that difficult balance. And I think you're right to say that most hospitals are really difficult at visiting times to get access to, really, at this moment in time. I think what we're talking about with this change, though, are that we're talking about there's only 800 people that'll be affected, so it's not a significant chunk of movement. And with the repatriation plans as well, that when people if they are for an extended period of time and they're in a rehabilitation phase, they should be moved back to their more local hospital to have their longer term rehabilitation period, really.
The answer to that question, no, basically.
Well, I think...
And with all due respect, we as chairs of Scrutiny and members of Scrutiny, when changes come, especially when the specialised service, it's always only small numbers, but only small numbers add up and add up and add up. Councillor Ladd.
Thank you. And the only small numbers, you said yourselves that a high proportion of the people that we're talking about are elderly, because arterial vein problems crop up in elderly people. And I think coming from Leeds, which has been denigrated to some extent for being Leeds, but we've experienced this. One, we have a lousy bus service. Elderly people aren't always drivers, therefore they do rely on public transport to get about. And we have found in Leeds that it is possible, very, very possible, for people, for elderly people, to have to spend weeks apart simply because they cannot get to see each other. And that even carries on when you've got them out in a bed in the community recuperating. So what, the area we're talking about here, that exacerbates the problem, doesn't it? Because, you're travelling between towns rather than trying to get around one, or cities, should I say. So I say that in support of what has been said before.
What you say is true. I mean, it's a truism. Our difficulty is that we want to try and get the very best outcomes. We want to increase the chances that people will live and be able to, go home and be with the people who love them. So increase the proportion of people ultimately over time who are alive. And so
I think what we're not saying that we don't. We're not saying that. What we're asking is about what you're doing about it for the mitigation purposes, which is why I addressed the comment to Wire. Yeah, thank you.
All the trusts have problems with parking access, and we cannot. It's not in our power to be able to lay on transport, and I suspect it would end up not being very well used either. But I don't know. We have to accept that there is the disbenefit of having specialised services delivered out of larger centres in fewer places is that access isn't as easy for everybody as it was before. And it's really difficult to totally mitigate that. And in fact, we can't mitigate some of it. Some of it just is more difficult for people. And we're kind of putting it forward, recognising it's more difficult for people, but believing that disbenefit, because it is a disbenefit, is balanced, more than balanced, by the fact that there's a greater chance of people surviving, getting the most expert interventions that they can. In a way, it's almost like you can't have this omelette without cracking this egg, and it's a disbenefit. And the mitigation we can do is limited. We can't do that much mitigation. We can tell the organisations it's happening. We can recognise it's a problem. Trusts all know that parking is a big problem, and they're limited in what they can do because they might not have space, and it is a problem. So I think we recognise it as a problem, but we put this forward because we still think it's the right thing to do because of the improved outcomes for patients.
We're not disputing the reasoning behind it. I think the question is in terms of the constituents and their families and their well-being when a patient is in that position, and the best way to get patients feeling better is by their families being able to visit them. They feel less isolated. But I think there might be some learning that you might want to discuss with the Mid Yorkshire Trust that Councillor Smage and I were involved in when there was some reconfiguration. And you might want to speak to and take on board these issues rather than saying, well, there is a concern and we understand it. How about speaking to the Combined Authority, as we did, through the trusts, and ask them to engage and to put a bus service on that actually went from Wakefield to Pontefract and Wakefield to Dewsbury and vice versa. There was connections for people for this particular reason. So, I'm sorry, I'm one of these that I don't believe there's never a can't. I always look to say, well, there should be a can explored. And why isn't that being explored? There's recognition it's an issue. Speak to somebody, see what can be done, and then come back and say why they say they can't, rather than you as an organisation collectively saying, well, we don't recognise it's there, but there's nothing we can do. We experience that, and it works.
No, thank you. That's useful, and we're happy to learn from that. And with you outside, that'd be really helpful. Thank you.
Anybody have any further questions they wish to raise? Councillor Hutchinson.
Yes, sorry about that, Chair. Two things that were mentioned in the consultation. One was the letter from the Royal College of Radiologists, and one was the British Society, the letter from the British Society for Interventional Radiology. And I appreciate that they were concentrating on the non-vascular side of things, but they've been quoted in the consultation report. Can I ask the Chair whether we can request to see their responses in total, complete, rather than just the quotations that have been taken from them?
No problem with that, Chair, absolutely.
Thank you. And the other thing is that a number of concerns have been raised regarding the implementation of these plans. And I would like to ask whether the West Yorkshire Joint Health Scrutiny, I know this body, once we've responded, has finished its remit, but to ask for continuing engagement of the West Yorkshire Joint Health Outcome and Scrutiny Committee to see how these proposals are actually embedded in practice, assuming they go ahead, rather than this being an end to the engagement.
So that takes us on to next steps. I've made some notes about things we've picked up on, and so maybe we can talk about next steps as we're moving forward. Okay, so you've said that you will, instead of just writing a letter, you will explore better transport links with the combined authority, and I think we would want to know what the result of those discussions are, please. Okay. Do we believe that the consultation has been carried out sufficiently? Do we think that yes, the consultation has been carried out sufficiently? Okay. We've talked about rehabilitation, and I think we'd like to see the protocol and the model to ensure that is what's been discussed here. We would like to see that.
Can I clarify, is that repatriation as a whole or just the rehab patient?
Both. Repatriation as a whole. Okay. Yeah, both, yeah. Okay. We'd like the full information, as Councillor Hutchinson has said, from the all colleges, etc. We would also like to understand the modelling of beds across as well, yes? So when the modelling has been carried out, we'd like to understand that. But I think one of the concerns is the sustainability of services for the future. Both the sustainability of the vascular services in 2 centres, but also the sustainability of services where there'll be the spoke hospitals, as they're called, going forward as well. And I think we would like far more reassurance on that sustainability. I still do not see, and I'm sorry, but I still do not see how the networking is not part of the decision process. And I would have thought that the networking for both vascular and non-vascular services, bearing in mind, because I think I wrote it down, because of the uniqueness of staff in common at CHFT, that whilst this is a national standards, etc., NHS England should have worked far more in partnership with local organisations to have had something in place to describe to people about the service going forward. And I think that should be part of the decision-making process. Is that agreed? Have I missed anything? Councillor Rhodes.
Can I just add one thing in terms of protocols and the memorandum of understanding? We would need to make sure that these have actually been agreed by the various bodies and signed off, because afterwards it could be said, well, it was only an agreement in kind. But I'd like to see who signed them off and make sure that everybody has that knowledge of their part for the future, should this be a proposal that does go ahead.
Normally, I would anticipate some kind of audit process for how successful it's been after a year and 2 years? I mean, things like repatriation, all the things we've discussed, and complaints about management, etc.
The papers mention performance will be monitored through cancelled procedures, but I think we perhaps want more information as to perform and how the service is going forward, rather than just on cancelled procedures. Yes, a continued overview of the service and the sustainability of it going forward, because we're also concerned as well that if this doesn't work and there's more pressures on Leeds, then that could affect the Leeds side of the vascular service and the mid-Yorkshire side of it, yes. And bearing in mind that half of Kirklees goes toward mid-Yorkshire and half goes toward CHFT, yes, I think that's from a Kirklees perspective as well, that would be important. Are there any other points that anybody wants us to raise as concerns or recommendations? No? Okay, thank you very much. We will get those to you. I think we've got a fortnight in which to respond. So can I ask that the committee, if the committee are happy, for the wording of those recommendations to be delegated to myself and Councillor Hutchinson, and then we will email them out for the committee to comment on before they are sent off. Is that all right with everybody? Yes? Yeah. In good time. Absolutely. Thank you. No. Thank you very much for today. Thank you.